Welcome. Welcome to this Creativity and Social Prescribing webinar that we're having here today. I'd be very grateful if you'd like to put your name and where you're from in the chat. It'd be nice if people want to link up with you or hear about different things across the world. So please do let us have a go in the chat if you want to sit, so we know who's here. And we will be starting very soon. I'm going to be sharing some slides and then I'll be telling you about what to expect today. Thank you. Right. So I presume you can see my slides.
Yes, we can, Esther.
Lovely, thank you. I'll just start from the beginning. So hello and welcome. My name's Esther Watts. I'm the Creative Health Associate for the South East from the National Centre for Creative Health. And I'm also I'm based in the South East, but I'm currently hosted by Sussex Integrated Care Board. And this is our Creativity and Social Prescribing webinar. The thinking behind this webinar was that how can we connect health and creativity through local social prescribing? How can we make sure that there are creative health activities for social prescribers to refer to that are free at the point of delivery, supported by skilled practitioners, able and trusted to support people? What are the models currently employed to do this? So people here presenting their work will be talking about the different ways that it's done. And we wanted to share those models so that more people can commission creativity to prevent and address health inequalities, isolation, and increase health and well-being. So the agenda for today's webinar, we have me welcoming and introducing right now, and then we'll be hearing from Monica Boulton from the National Academy for Social Prescribing. We're looking at the Gloucestershire model with Dr. Simon Opher MP, and a Welsh example, Hywel with Kathryn, Lambert and Rees. And last but very much not least, Wells City Salisbury with Lee Chalmers and Zoe Pritchard. And then there'll be the chance for you to ask questions. So it's going to be quite tight, but I think it's really interesting information. I'm hoping you're going to enjoy it as much as me. I am just going to say a bit about the National Centre for Creative Health. We are a charity that was created as a result of the first Creative Health Review by the All-Party Parliamentary Group on Creative Health in 2016. And you can see what we're doing. We're doing that now. We're promoting collaboration, good practice and research. Creative health is creative activities and approaches that have benefits for health and well-being. And this can be done in a variety of ways and in a variety of places. So, for example, at home, that second picture's in the library, in cultural organisations and places. This gentleman down here is painting in the care home and, of course, in hospital. So now, without further ado, and that very quick spin, I'm going to be inviting our first speaker to talk. So, Monica, hello. The floor is yours.
Thank you so much, Esther. Yeah, thank you so much for inviting me to speak at this webinar today. It's a real pleasure to be here. So I'm Monica Boulton. I'm the Healthcare Integration Lead at the National Academy for Social Prescribing. But I've also always had an interest in creative health and in particular how music can support people with dementia, which I'm really fortunate to have had some experience in delivering. And I'm also a very proud board member of a small CIC in Kent musical walkabout. So I feel very much among friends here today. But anyway, we at NASP often like to start our presentations by reminding ourselves of the internationally agreed definition of social prescribing, as it really helps to ensure that we are singing from the same hymn sheet, as it were. So this definition is particularly beneficial as it really helps to describe the function that social prescribing provides. So to operationalise this definition, I think it's helpful to see it broken down into three separate parts. So we have the trusted individual in a clinical and community settings that are are identifying that people have a non-medical but health-related social need, and then we have that subsequent connection to non-clinical support and services within the community, and that's done through co-producing a social prescription. And then that third element is the crucial non-medical prescription that has the ability to improve the health and well-being and to really strengthen community connections. But why? Why do we need social prescribing in the kind of current context of our health and social care system? So firstly, we know that people are living longer, but this doesn't necessarily mean that people are living better. So the Darcy report and reports by the Health Foundation reference this widening gap between life expectancy and healthy life expectancy. And this expansion in unhealthy years of life has got really large implications for both our health and care demand, as does the increase in people that are living with long-term conditions, and medication use is rising as a consequence of that. In fact, the average prescription per head between 1994 and 2018 has actually doubled. And also, despite this recent investment and shift to more of a personalised care approach within our health and care system, a recent survey conducted by the PCI, the Personalised Care Institute, demonstrated that 44.6% of patients actually want more involvement in their healthcare decisions. So social prescribing is usually recognised and embodied through the role of the social prescribing link worker, that connector role, but we also must recognise it as a broader key component of personalised care that represents this culture shift that we need. So the evidence base for social prescribing is growing rapidly, and a recent NAS report summarises the analysis of data from 9 local health systems, and that shows that social prescribing can substantially reduce pressure on the NHS. So examples include a reduction of 42% in GP appointments in Thameside and Glossop, and a 23% reduction in A&E visits in Kent, and also other areas such as Newcastle reports a reduction in secondary care costs that were 9% lower where social prescribing was available to individuals. We also know that social prescribing can improve health outcomes, and it is shown to reduce anxiety and improve life satisfaction through the cross-government Green Social Prescribing evaluation that was launched later last year. And finally, though there are systemic challenges in tackling health inequalities, and social prescribing is not a means to address all of these things at an individual level, it can really make a significant difference, and that's being shown through some of the evidence that's emerging. So what does this actually look like in practice? So this pathway that I've kind of pulled together here is representative of that global definition that I referenced earlier, but it also prompts us, I think, to think about social prescribing within a kind of whole system sort of context. So investment, resources and tracking across this pathway need to exist for social prescribing to really thrive, and that absolutely demands collaboration. So this pathway, as well as that system context, also helps us to understand that point I made earlier about social prescribing needing to sit on more shoulders than just that of the link worker. So I wonder whether I could just kind of break this down a little bit through a theoretical case study that's based in some of my experience of being a link worker many years ago. So let's call them Alex. So Alex is an individual that has become increasingly isolated due to a recent bereavement and is also experiencing cognitive decline. Now, the traditional route may be that Alex visits her GP for a routine visit, who sees and recognises that medication isn't able to solely address these issues, and refers them into the link worker. That link worker has been recruited purely to give that individual time to connect with that individual, understand that they no longer maybe have access to their own finances, which is the barrier in them engaging with activities such as a music group, which could support with addressing their loneliness as well as their cognitive decline. They then, with an understanding the link worker, work with that local community, work with an activity provider to get them proactively involved, and subsequently Alex then becomes more engaged and involved in their community and healthier as a result. However, let's theorise that Alex is already under specialist care due to their cognitive decline. So they may have already been in contact with a service that understands what matters to them, a clinical service, and be able to that service may be able to perform that function of both the identifier and the connector, utilising the resources at the end of the pathway, that prescription. And this could be summarised perhaps through another health professional adopting a social prescribing approach. Another scenario may be that Alex has already connected with the music group. They've come in at that prescription end through their own means, through their own agency. Now, that doesn't mean that they don't come through the door with other health and wellbeing needs, and they may still need connecting to social prescribing. That's where the importance of the pathway functioning kind of both ways comes into play. And if the system is well connected, the activities can then perform the function of the identifier and the activity provider, but refer into that connector so that the service doesn't sit in isolation to that individual's needs. So ultimately, what matters most through this pathway is the difference that it makes to those that we're trying to support, and embody that many ways to many approach. So an integrated approach that meets people where they are. So focusing on that prescription end of the pathway, which is of course where many of those creative activities sit within it, I thought I'd pull together some of what I think are sort of the key ingredients, if you like, for this part of the system to really thrive. So at NASP, we often reference the pillars of social prescribing, and these are the categories that are outlined just on the right-hand side of this slide. I think it's important to recognise these, though, as not separate, because there's so often a real interface between these different sectors. So, for example, nature-based activities often incorporate physical activity too, hence why that cross-sector collaboration is absolutely fundamental within these systems. And these systems really need to work together for an individual, and this can be enhanced through integrated and connected commissioning across the pathway, seeing it in the context of that system. It's also really vital that services are equipped to support individuals that come through potentially with complex and advanced needs, specifically through those social prescribing referrals, and creative practitioners should be valued as part of the social prescribing workforce, I think, in order to enable this approach and that protection around that workforce. I also think it's important to place a value on of course, the benefits of these activities, but they also transcend the specific activity themselves. So giving the opportunities for individuals to connect to others, to themselves, to their wider community is absolutely vital. So again, that kind of connection within the system is really, really important. And finally, the richness of the social prescription enables choice and personalisation for individuals, particularly when it's offered as a targeted intervention for specific cohorts. So understanding what works well for individuals is really, really important. Now, what is often the elephant in the room, and indeed the largest barrier to success in this space, is the need for that long-term and sustained investment into those activities. And NASP recently launched our Shared Investment Fund report, and essentially this fund aims to tackle the currently short-term and fragmented funding by proposing a £1 billion fund across 10 years that brings together public, philanthropic and private investment to build those thriving communities and support social prescribing activities that is proportionate to the local health need and what the wishes of that community are as well. So this essentially is a call for a fund that would support the growth of existing and new provision and really widen the reach of social prescribing. In the short time that I've got left, I'm conscious of time. One example of this is our current work around the Power of Music programme, and that really aims to strengthen the support that's available to people living with dementia, in ensuring that they've got access to music, which we know has got so many benefits for people living with dementia. And the fund has raised over £2 million, much of which is going directly into local organisations. And I don't have time to go into the detail on this today, but you can view loads more about both of these two different projects that I'm talking about on our website. And I'll also perhaps pop a link into the chat, which to Music Can, which is a directory of support and links to playlists and things like that might be of interest to this audience as well. But as I'm so conscious of time, there are my references, so you can look at all of the kind of different reports and evidence that I've referenced today. But that just leaves me to say a huge thank you, and really looking forward to hearing the rest of the presentations and having a discussion through Q&A at the end. Thanks, Esther.
Thank you, Monica, and how marvellous. You were on time, and such brilliant examples, such a great description. Thank you. Now I'd like to introduce Dr. Simon Opher MP to talk about his experience in Gloucestershire.
Right. Hello, everyone. Yeah, thanks for attending this webinar. And thank you for the NCCH for organising it as well. Yeah. So my name's Dr. Simon Opher. I've been a GP all my life, really, and about 30 years in Gloucestershire. And in July, I got elected as a Labour MP for Stroud. So I've got a new hat on now. I still practice occasionally, about once every 2 weeks. I do a surgery, which I love still, actually, I must say. And a little bit of history. Back in 2000 or so, I started using artists in residence in my surgery, and from that gradually evolved a service for people in Gloucestershire, which I'll outline in a bit. But I'd like to go through a couple of things. So the first thing is, while I've been in Parliament, we've recreated the APPG, which is the All-Party Parliamentary Group for Creative Health, and we've done our inaugural meeting, and we have a meeting coming up at the end of March, and we're planning to have quarterly meetings of that going forward. So that's really exciting, and I'd like to pay tribute to everyone in the past who got the former All-Party Parliamentary Group going, and often really galvanised the creative sector in art and health. So that's fantastic. I also chair the All-Party Parliamentary Group for Health, and also another one called Beyond Pills, which is actually very linked to it. And I'll come on to that a bit later, because we have got a real problem with over-prescribing in this country. Just for a bit of context, I also chair I'm a chair of the Net Zero Committee, but I also chair the Opera and the Archaeology All-Party Parliamentary Group. So I'm a bit of a magpie in that way, and that's how I like it. I think, and one of the things about social prescribing is that there's so many different things that fit into it. I find that really exciting. So what happened in my surgery was we started to do we started with a potter, and then we had a fine artist, and we had a poet, and what we noticed was that people stopped seeing the doctor nearly so much when they were seeing the artist, and obviously that has health cost implications, but it also has well-being implications, because often instead of going on a medication, they have something much more positive. And I'm sure most of you that are signed up to this call will understand and have seen this yourself. So that's how I got so excited about it. And we've done quite a lot of things. We've done quite a lot of dance as well, ballet post-mastectomy, for example, music with dementia and singing for dementia. And my most recent one, which is actually since I've been in Parliament, is trying to use comedy to see whether that makes people better. And there's a long history of this, really, in that there's been clown doctors in the healthcare settings, particularly on paediatric wards, which so we're sort of following on in that. And comedy is quite interesting, because one of the things they do in comedy is they take a standard situation in life, and then they look at it in a slightly different angle, which in comedy terms makes it funny, or it reveals something about it. And I think one of the real beauties of creative health and of using the arts in healthcare is it helps people see, reframe, as it's termed in psychological parlance, actually look at life in a slightly different way. And I'm pretty certain that's one of the reasons why it's so beneficial to people, and particularly to their mental health. So just carrying on. So very briefly, the three paradigms that that Wes Streeting, the health secretary, is looking at in health. It's important to sort of understand that. I think the first one is from cure to prevention, and I'll talk about that a little bit later. And then there's from the hospital to the community, so getting people out of hospital and looked after in the community, and then going from an analog type service to a much more digital online type service. And I'm particularly interested in the prevention side, because we know of the preventative things in physical health, like diet, exercise, stop smoking, etc. In mental health, there's not that much in the cupboard, and I do think that social prescribing and artistic creative things specifically could be the real, could be incredibly strong preventative healthcare in terms of mental health prevention. So what does that look like? That looks like providing lots of art services for patients, but it also I'm trying to campaign to get more music in schools, for example, and make sure the arts is really embedded in the curriculum, so that I think that will improve people's overall mental health as well. So just very briefly coming on to mental health. So in terms of, we've got a problem in this country. 8.7 million people have been prescribed antidepressants in the last year in England alone. So that's 1 in 5 adults, 20% of adults are taking antidepressants. And to be honest, that's I think that's scandalous, really. I think that's vast overtreatment. And what I think is happening is patients with mild to moderate mental health symptoms are given antidepressants simply because there's nothing else available. And psychological treatments, as many of you will know, take a long time to come. Now, I must emphasize that I'm not saying that antidepressants are a bad idea. They're really fantastic for people that need them. I just think a lot of people that don't need them are being given them because they lack a social prescription, actually, and that's one of the things where I think we can really help in that way. So that's something that I'm really keen on, to try and change that round, get people off antidepressants, so that if they come in with mild to moderate depressive or anxiety symptoms, they get referred to a social on a social prescription or a creative prescription before they get given antidepressants, and that will be a real result if we can make that happen. And again, that will give not only will the patient get better, but also it will save the doctor having to, follow up. It will save over medicalization of that patient. So that's really, that feels very exciting to me. So I've got about 2 to 3 minutes left. I just wanted to say a little bit about what we're doing in Gloucestershire, which was meant to be the remit of my talk. In terms of in Gloucestershire, so we started off about 10 years ago, slightly more than that, where we commissioned a service for social prescribing link workers county-wide, and that was 2/3 funded by health and 1/3 funded by the county council. Now, just recently, everything's slightly changed in social prescribing because primary care networks, or PCNs, now have the ability to employ social prescribers. So, for example, in my area, we have a young person social prescriber and an adult social prescriber. And so what's actually just happened recently is that the ICB and the county council have taken money out of the social prescribing link workers that were being provided by the county and now are provided by the PCNs, and they put that money into the actual providers of the social prescription. And that's one of the things that has been a major complaint over the last 10-15 years with the arts in health, is that it's great to get a prescription for the arts, but where's the money coming from? And the money was coming really from the arts budget, which isn't massive. And I think this is really quite an exciting development. So money's being put into that. That does depend on the primary care network employing a social prescribing link worker, of course. So that's really important. But it's quite an exciting model in Gloucestershire. I think they have the sort of standard social prescribing, and then they have something called Social Prescribing Plus, which is specific, and many of you will know what this is, even though you perhaps don't call it that, which is when you have a specific service for a specific creative service for a specific disease. So, for example, I mentioned post-mastectomy ballet, for example. You can have creativity workshops for people with chronic pain, which has been really effective. So instead of just having a generalized treatment, you actually specify exactly the sort of disease modality that these things can do. And that's been really quite successful, and it's replaced more medicalized systems. So that's really exciting. I'm just going to finish now, but one sort of plea from the doctor end of things, so the referrer end of things. I think the one thing that we don't do very well is do a very short feedback to the referring clinician. And that just involves, I think, one paragraph just saying they seem to have got a lot better with doing this, or they haven't got much better and they might come and see you again. But some sort of feedback will actually enhance the sort of circuit of social prescribing. So if there's one take-home message, make sure you do a feedback, not too long, because doctors have very short attention spans, but maybe 3 sentences or something about how a patient has done, and send that back to the referrer. So that would be my plea. So thank you for that, and I'm going to stay on the call to answer any questions if there are any later. Thank you.
Thank you so much, Simon. That's brilliant. It's a whistle-stop tour of some very interesting things. There's lots to unpick. I'm sure you'll get a question or two. And next, I am going to welcome Kathryn, Lambert and Rhian Rees from Hywel. Would you like to take the floor, please?
You're on mute at the moment.
Thanks, Simon. Thanks ever so much for inviting us to come and share today. My name's Kathryn Lambert, and I'm the Head of Arts and Health for Hywel in the west of Wales. And I'm be sharing today some of the work that we've been doing with my colleague Rhian Rees, who we're working closely with in the public health team that's based in the Health Board, who's Senior Health Practitioner here. And I'm just, if you can move the slide, Rhian. Yeah, so just a little bit of an introduction. So obviously we're working within the Welsh national context, different model. The role that I have, I've joined the Health Board from a career within the arts sector. So I've worked for over 20 years within the arts sector, coming into healthcare latterly in the last couple of years. And based within the patient team, with a remit to look right across patients, communities, staff, and families of patients, and built very much on the growing body of evidence that I think the group's all familiar with, but in Wales founded on the Memorandum of Understanding between the Arts Council of Wales and the Welsh NHS Confederation, which is very much around putting the arts at the heart of service transformation. We're part of a national team, so again through that MOU, a national team of arts and health coordinators exist within each of the health boards, the 7 health boards of Wales. And again, we're all members of the Welsh Government cross-party group with a big agenda, really nationally, fast-moving agenda around the promotion and integration of arts for health. A couple of key points within Hywel. We are serving a very rural, coastal, bilingual and really large geographical area. Numbers of people here are much, much lower than in many parts of England. So we're under 400,000 people, covering spread across really a third of the footprint of Wales. So some of the schemes and initiatives that need to be developed and services being developed across Hywel need to very much bear in mind that overall context. If you can change the screen. So what we have been able to do at Hywel is there's a huge interest, huge will and enthusiasm around trying to look at how we can incorporate the arts within healthcare. We have been able to publish an Arts and Health Charter as a health board, which is really a public pledge to put creativity at the heart of health and wellbeing and integrate the arts into the work of the health board to improve health and well-being and promote healing and recovery. And it's centred really through a set of arts and health principles that are centred on showing how this incorporation could help the health board to achieve its own strategic objectives and benefit people right across Mid and West Wales. So this is guiding much of the work that we're doing in this area. And if you can next slide, please. Very much one of the key elements of that really is around better connecting people with arts and health activities in their local communities to help people to feel better, happier, lead more joyful lives, have more support with staying well in their own community and have more control over their own health and well-being. So we've been doing that, and it's a big focus of some of the work and programmes that we've been able to develop over the last couple of years. Next slide, please. And we just wanted to quickly explain, and then Rhian's going to talk in some bit more detail about the project and the pathway we're currently developing. But it's come out of a 2-year programme of work, again funded by the Arts Council of Wales, to look at how to integrate arts on prescription into social prescribing practice right across Hywel. It's again a partnership with the public health team, Public Health Wales, Wales Arts Health and Wellbeing Network and 6 other arts partners working across the region. We've worked with our own evaluation team within the research team at the Health Board to produce a report which has been published, and are trying at this stage to take forward some of the 4 key recommendations that were laid out as part of some of that work over that period. And at that point, I'm going to hand over to Rhian, who's going to tell you a little bit about the project we're trying to do to take forward some of that learning. We can't hear you, Rhian, either.
Apologies, I can't actually see any of the buttons or anything when I was showing the slides. So I'll carry on now. Yeah, okay, thank you. So as Kathryn says, there were 4 key recommendations that came forward out of all the work that went on with the creative conversations and things. And what we've been trying to do over the last months is to put together an integrated, equitable, co-created, ethical test model for arts on referral that we can actually evidence some of the benefits that we know are there. So how have we done that? We've co-created a logic model with our partners that addresses pressing concerns in primary care, utilises intelligence from a wide range of stakeholders, and addresses the recommendations, and tackles inequality. And one of the key drivers for that has been this knowledge that activities that are offered under creative prescribing can empower people to address the psychological and wellbeing issues that are often found in people who frequently visit the GP. Okay, so the next slide shows the range of partners that we have worked with in order to generate this model. They're not put in any order of importance, they're just put on the slide there. So who are we targeting? We, in conversation with some of the GPs and service managers in West Wales, some of their concerns were around people who frequently attend at GP surgery, who are having the support that they can have in terms of medical intervention and biomedical model. And there's a recognition that actually some of their needs could be met in a broader sense, and that could help to alleviate some of their related anxiety, potentially depression. So these are people with chronic conditions or chronic pain who are regularly attending more than once a week at the GP surgery. And as a result of their condition, they might also be socially isolated. And then we've got some data on, we know that this is going to be affecting people who are living in areas of deprivation more. Got some data from England suggesting that the chronic conditions contribute the most to health inequality, which is one of the reasons why we've gone for the chronic conditions. There's a 5-point gap in the number of GP appointments per 100,000 population between deprived and least deprived areas. And this is terrible. Women in Wales born in the most deprived areas on average live 18.3 years of their lives in poor health. That's very, very sad, and it doesn't need to be like that. So what are the outcomes that we're looking for? We want to improve patient well-being. So that includes mood, mental well-being, and reduce their social isolation and help them to build social networks. We want to introduce patients to an arts-based means of managing their well-being and reducing their isolation and their anxiety, finding a different way of managing things. And as a result of that, hopefully reduce their GP appointments or their needs, their understanding that the GP is the only person that can help them with their health. They've actually got means to deal with some of the symptoms they're experiencing themselves. And also to increase their confidence and awareness in utilising ongoing social support and information, and ultimately the patients feel enabled to support their own health and well-being. So how are we going to do it? We've got an 8-week local programme, so it's going to be delivered in the local setting of co-produced arts activities. So that's about working with the artists to co-produce what exactly is going to happen over that 8 weeks, because we wanted to start with giving people a sense of agency from the beginning. There will be a gentle 15 minutes of movement, because we recognise that some of these people are probably not moving quite enough, and it's a good way of kind of grounding yourself in the room. Introducing, through the course of the 8 weeks, they will be introduced to key sources of support or information. For example, the community connector, lifestyle coaches, the Be Well service is a patient information service delivered by people who have lived experience of chronic conditions, and also introducing some of the apps and websites that could help them. We'll have transport. So these are some of those apps and websites. I'm just looking at the time now. And why? How are we going to evidence the outcomes? We really need to evidence the outcomes in a convincing way. So we're going to be able to gather some information on the number of visits to the GP surgery pre-intervention, 6 months pre-intervention, during and 3 months post-intervention. And then in terms of qualitative information, we've got support from the TriTech team, who are a research and evaluation branch of Hywel University Health Board, who are going to come in and do some of these assessments. So we've got the short Warwick Edinburgh mental wellbeing scale, and we've got a lovely new South Wales social wellbeing scale, which we're going to be testing. And we've also got a patient activation question, which is just kind of, other than coming to the group today, what are you kind of doing to look after yourself? And those questions will be asked at week 2, week 8, and 3 months post programme. And there's the logic model there. And I'm going to stop there because I'm 20 seconds over, sorry.
Lovely, thank you. Just a quick one there for Rhian and Kathryn. What are the community settings? Are you linked in with libraries?
It'll be the artists who identify the most suitable community settings. But I mean, a lot of our libraries are closed in West Wales, unfortunately, but we do have sort of combined libraries and local authority settings, swimming pools, wellbeing centres, churches, church halls and things. There are lots of settings that we'll be able to use.
Thank you. Thanks very much. Thank you so much, Kathryn and Rhian. It's very interesting to see the different models and how they're working and the different ways that we're supporting creativity. Next, we're going to hear from Well City Salisbury. So Lee and Zoe, would you like to take the floor?
Absolutely, thank you.
Esther, could we just stop sharing the last slide, if that's possible?
Oh, sorry. Apologies.
There's so many buttons to press, Rhian, isn't there? Meeting and sharing and not sharing, and then you lose yourself. So yes, let me see if I can share our slides.
Thank you.
Okay, can you see that, Esther?
I can.
Amazing, thank you. Okay. All right, let's begin. So hello everyone, it's lovely to be here. I'm Lee Chalmers and I'm the Heritage Inclusion Manager at Wessex Archaeology, and I'm joined hopefully by my colleague Zoe Pritchard. Zoe dropped off my screen, so I hope she's still there. And Zoe's our Well City Salisbury Project Coordinator. And we're here today to give you really a whistle-stop tour of our Social Prescribing cross-sector partnership project. So what is Well City Salisbury? Well, as I've said, we are a cross-sector partnership and we're working together in Salisbury supporting people who have low to moderate mental health needs. We're in our 4th year of delivery now, having successfully secured funding for another 3 years worth of delivery back in October last year. Between us, we can offer people course choices that are reflective of their interests or things that they might like to try, things that they're curious about, or something that might be brand new to them. And these courses play to the strengths of our individual organisations. So for example, my courses obviously always have archaeology embedded within them. We work with artists to bring the creative element. So each course has 2 people leading. We have the artist who's responsible for the creativity, and we have the facilitators who are responsible for the well-being of the participants. We're working with external evaluators who objectively assess the impact and the difference attending a Well City course makes to an individual, and our evaluation always also extends to the experiences of project partners, artists, referrers, and the wider community. So there are 4 partner organisations that make up our partnership. Excuse me. ArtCare are based up at Salisbury District Hospital and they deliver creative opportunities to patients, visitors and staff. We have Wiltshire Creative, who comprise of the Playhouse Theatre, the Arts Centre and the Arts Festival, and they cover all things performing arts. Wiltshire Wildlife Trust bring in access to nature and blue and green therapy, and Wessex Archaeology for that lovely fix of heritage, people, places, objects and landscapes. And the benefits of a cross-sector partnership is that between us, we do provide our participants choice, as I've said, but also there's an opportunity there to explore a pathway between the 4 partner organisations and to the wider things that we offer as those organisations. We're delighted to be funded again by the National Lottery Community Fund, and we've been given 368,000 towards the project. And as you can see from our slide, we also need to obtain another 108,000 in match funding across the next 3 years. So for our match funding, we're going to be applying to Arts Council England, Wiltshire County Council, Salisbury City Council, to name but a few. There's going to be many, many funding applications going in. We're very fortunate in that across our organisations, we have members of staff whose job it is to support us to write these grant applications. But I'm sure you all know that grant applications take up a lot of time and a lot of energy, and it's going to be an ongoing process for us over these next 3 years. So I'm going to hand over to Zoe now, who'll be able to tell you a little bit more about our project model and the work that we do with referrers.
Thank you, Lee. So as part of the Well City Salisbury model, we deliver 24 free 10-week creative courses over 3 years, working closely with local artists and creative practitioners to bring each course to life. We are committed to ongoing training, moments of reflection and shared learning for everyone involved, including project staff, artists, volunteers and the wider community. Our programme also offers mentored opportunities outside the standard course model, where participants can get involved with a personal research project to deepen their creative practice with one of our partner organisations and artist mentor. Beyond the courses, we run monthly events like Art Club and participant training sessions to keep people connected to each other, the project and keep creativity flowing. And each year we come together for a special celebration and exhibition to showcase participants' work and celebrate the collective impact of the project on our community. Everything is free for our participants to attend. We cover all the cost materials, plenty of refreshments, and we can also cover the cost of transport as well. It's worth mentioning that Art Club wasn't part of our original funding bid, but was creative in direct response to participants' feedback and evolving needs. As a partnership, we are very reflective and use a holistic, person-centred approach. By listening to our community, we ensure that the work truly reflects the needs of those who we support and makes a lasting impact. Next slide, please. Thank you. So after 3 years delivering Well City Salisbury, we have evolved to deepen our impact and better meet the needs of our participants and the wider community. In addition to the project partners, we also work on a guest delivery partnership model where we bring in other organisations to deliver a course. These organisations are fully supported, trained and inducted into the project. This way of working also allows us to expand our reach even further, supporting other organisations, and we hope will strengthen the legacy of the project. Over the past 3 years, our courses have been open to anyone experiencing low to medium mental health needs, such as anxiety or depression, but we are also now working with more targeted groups, such as Headway, the Brain Injury Support Charity, to create courses that are more bespoke to the needs of that particular group. We have a monthly art club, personal projects and participant development offer, which keeps participants connected to the project. Art Club also acts as an entry point and can help people build up confidence and create a supportive pathway into our general courses, ensuring that everyone feels welcome and empowered to explore their creativity and well-being. Next slide, please. So Well City Salisbury mainly uses a social prescribing model where participants are referred or signposted onto the course by their GP practice, support organisation, or social prescriber or link worker. We also welcome self-referrals if that route doesn't work for people and where they currently are on their wellbeing journey. We have built our team of referrers to over 18 referring partners, including local doctor surgeries, community mental health teams, the job centre and local councils. We actively attend local coffee mornings, network events and council meetings to share the project and meet potential new referrers. Aside from referring participants, our referrers also provide critical ongoing feedback to shape our courses, opportunities and process. They are integral to our project evaluation, sharing their views and as part of our celebration events. Next slide, please. So we offer 2 routes to joining a course, referral and self-referral. Initially, self-referral was only available to those who had already been referred and completed a course with us. This decision provided us with a safety net, ensuring that identified referrer could offer support if someone was to experience a mental health crisis during a course. We soon realised that this approach actually created significant barriers for many reasons. Many people who might benefit from our courses and experiencing poor mental health, just weren't at the stage of having access professional support. Some referrers also prefer to encourage people to self-refer as a way to help people take ownership of their own mental health journey. And as well as our confidence has grew in delivering courses, we've become more comfortable without always needing the referrer safety net. For self-referrals, we also ask participants to identify a support person, someone that they would feel comfortable talking to about their mental health. This could be a professional, friend, or family member. While not a perfect solution, some participants really struggle to identify someone. This approach also encourages people to consider their support network. It also reflects a key learning from the project. Sometimes there are no perfect solutions. And now I'm going to hand over back to Lee, who's going to be sharing how we support ourselves as a team.
Thank you, Zoe, and apologies, folks. I've suddenly developed a bit of a coughing fit. So let's see if we can get through these last few slides. So I think it's really important that we all recognise the importance of caring for ourselves, actually, when we're doing this kind of work, because this kind of work is oftentimes quite emotionally challenging. I think we know that objectively, but it's often something that gets pushed to the bottom of the to-do list. So we thought it was important to talk about the ways that we've embedded caring for ourselves and our team into the project.
You're in the last minute, I'm afraid, Lee.
Okay,
so...
I'll be really fast. So as a team, we have external clinical supervision every 6 weeks, and supervision is a place for us to reflect and talk things through without the pressure of decision making. We can bring whatever we like for discussion, whether that's a challenge or a frustration that we're facing, something really fantastic that's happened, or questions about how and why we're doing things the way we are. In addition to supervision, we also have a peer-to-peer support structure, both formally through check-ins and check-outs for our staff facilitators and our artists, and more in depth at the end of the course, and informally amongst our team in terms of sharing experiences and seeking advice from colleagues when issues arise. To reinforce this, we actually attended peer-to-peer support training to ensure that we were implementing best practice. And that brings me on to training as care. So prioritising ongoing development and renewal through training means that we're prepared, we understand, and we're able to implement that best practice. And that gives us confidence to make change when it's needed. And I think something that's really important around this is training as a team whenever possible. And that includes the artists and the other freelancers that we work with. So really quickly, I'll let you guys read this slide. We have extended the level of care that we provide for the participants and staff delivery team to the artists that we work with. And on the screen now, you can see some of the ways that we support the artists and welcome them to be an absolutely integral part of the Wells City Salisbury community. And that's it from us. Thank you very much.
Thank you for an amazing presentation, Lee and Zoe, and all of our speakers. And now we're going to be moving towards some questions. So I've got a few down here that I've been noting down. So I'm going to go, there's a question for Simon here. Gemma Jolly has asked about the evaluation wrapped around the activity, especially social prescribing and creative activity. And I think this is, and there's another question about evaluation later. So how do we show the benefit through the evaluation, and what tools have you used?
Well, it's really difficult, isn't it? Because evaluation is always a sort of bolt on at the end, and I think it does have to be integral. I find it, you know, I do clinical things that don't have to be evaluated, but we are a new sort of idea, really. So we do have to do that, and the more evidence that we accumulate, the better. I think, I mean, in terms of, you know, we need to use validated scores like WebWebs and all that sort of thing around well-being. I think they're quite sort of straightforward to use. And also we need to use qualitative measures as well. So stories are really powerful and often sway things. But we need both, a little bit of hard data and a bit of stories. But we should, if we're suggesting a new service, you should really design it into the service before you start the evaluation, because it's sort of boring and it's a bit that we all don't want to do, but we have to do it, I'm afraid. It's really, really, it's like doing your washing or your washing up. It's not great, but if you don't do it, you never get anywhere, basically.
It all falls apart.
It does fall apart. So it's really essential we do that. So yeah, that's what I would do. And you can use formal mental health scores as well. I think numbers can be useful because they persuade people who aren't persuaded by stories. So we need both. I think that would be my my solution to that.
The one thing I also think, if we're counting what we care about, that I really like the idea of having the feedback to the GP. So what I really want a SNOMED code that the social prescribers say it was a creative activity, and then eventually that will turn back into how good this is. So, you know, it's counting, you know, the outcome, because often it's just they had social prescribing and it's not which bit of it. So I mean, I think it's also for social, for sport and physical activity and advice as well. Don't get me wrong. I believe in all the 4 pillars.
Can I just come in there, Esther? Because I think it's really important that we have measures that are useful for collecting that data, but are also useful for practitioners, that they can use those in a person-centered way so that it feels comfortable. But we've got to get that balance right of using a standardized measure so that it can be compared and contrasted with other things that are being commissioned, because that's often what commissioners will want to know is, are they getting as good as or better value for their money? And that requires a kind of standardized measure. So I think, though, we need to get that balance right, don't we, of measures that are appropriate for individuals and for people, but also that are going to be able to tell that story of this is really good bang for your buck, which we know that it is anecdotally and inherently within ourselves, but we do need that data to demonstrate that.
This is a difficult question. Does social prescribing framework include young people, or is there a separate system? I'm going to look to you, Monica.
So NASPA are doing quite a lot of work in this space at the moment, and we're hopefully going to be launching our children and young people's vision soon. So there'll be further details. That's a bit of a bit of a backing out response. But essentially, social prescribing was always intended to be a cradle to grave service. It's saying that it's an approach that works across the life course. But what I would say is that what we're finding as social prescribing is developing and growing is that actually you need a different set of skills and specialisms, and there is nuance required to appropriately support children and young people, and that often looks different to the adult model. So, for example, we know that children often don't present in primary care, so having a very primary care focused model is not always going to do exactly what I described earlier, which is kind of meeting people where they are. So often it is separate to the adult model, but things are growing all the time, and NASPA are exploring this area of work at the moment. So do sign up to our newsletter, keep an eye on our website for the development of that in the coming month.
Thank you. There's a very interesting question here from Sophie Waring, who has just been in my Sussex system. I know. Sophie saying, with a rolling out of AI in organisations, is there a risk of a missed opportunity of the AI identifying that A, the person presenting to the AI needs to be referred to a social prescribing link worker, or more specifically, has creative needs that are impacting the reason behind them presenting to whichever service they're presenting at? There's a future. I mean, so Sophie, at my point in this area, I'm not aware of AI being part of the pathway, but maybe it might well be in the future. So at which point we're definitely going to have to make a real effort to see that those persons' needs are going to be all covered. But I still don't think there's any replacement for a human talking to the person about their needs, and I don't think there will be in a hurry. I think that's the whole person-centered approach is the way to continue.
I completely agree with you, Esther, and I think AI could be useful for things such as screening risk factors that we know might help us to identify cohorts of patients that could benefit from social prescribing, but that shouldn't then become a replacement for that chance to have a what matters to you conversation, rather than we know that this works, so therefore you have to go and do it, because that's not the ethos of social prescribing. I think Simon wanted to come in as well.
Yeah, no, I was just going to say, in young people, I do think, I mean, it's a slightly more recent thing for me, but a young person social prescriber has been incredibly transformative in my practice, in that they not only do they link people to creative things, but they also liaise and form a communication sort of portal with schools and education, and because always with young people it's education, health, environment, everything's sort of mixed together, and they're brilliant at that. And I think that's what I love about social prescribing. They are looking at all the social determinants of health, and putting in a bit of creativity into the mix as well. So that's perfect for young people. And certainly, I mean, one of the statistics around antidepressants is that their use is rising quite dramatically in people under 18, and that's not clinically indicated either. either. So yeah, we must start doing more of that, I think. So that was what I would say.
Well, yeah, one of my passion projects was children and young people's social prescribing. Another one for Simon, is there any GP training in creative approaches to support health in your region?
I'm not absolutely certain about this, but I've read certain things which, because I'm part of a WhatsApp group with there's a special interest group of the Royal College of General Practitioners, and there's some amazing people on there who run education for doctors of the future, and indeed doctors in training to be GPs as well. So there is stuff out there. I'm not the best person to link up with, but we can find there's a lot of things going on, and I think that creative arts, I know in Bristol under Louis Uni, have been used in from year one, I think, or certainly year two, and it's been really productive, because a lot of medicine is much more reflective than we think it is. It's not just about learning the science, it's about understanding personalities and people, and if we don't do that part, the rest of the science just doesn't work really. So yeah, that's really good. So but if anyone wants, I think we can there'll be a lot of resource. If people haven't got any, let me know and I'll put them in the right direction.
Lovely, thank you. Yeah, I'm aware that in Brighton Sussex Medical School there's been arts in the curriculum for 20 years, but I've also been recently called over to Kelton Medway to support some medical students to learn about social prescribing and creative health. So it was my two favourites here. Thank you. But yes, there is the special interest group that the National Centre for Creative Health is supporting. So we are recruiting GPs all the time. I've definitely recruited some in my tenure here in Sussex. So I will be putting the information out for that. Well, let me give another one. So for the panel, this is from Jill Reynolds of East Sussex. So for the panel, we know that engaging in creative activities has a significant impact on reducing loneliness and preventing people from becoming chronically lonely, not just connecting with others, but giving them agency. But there's still stigma about asking people if they're feeling lonely. So how can social prescribing services and arts programmes capture feedback and evidence, reducing loneliness with this challenge in mind?
I think it is difficult asking about loneliness, so maybe that's the wrong question, really. But actually, just this morning, I was reading a book about community health and creativity, and loneliness is a massive, massive factor. So we need to embed that into clinical practice to really look for lonely people. If you say to someone, "Are you lonely?" they'll probably go, "No, I'm not lonely," because loneliness is a could be a pejorative term, couldn't it? So we need to say, what do you do with your days? What happens? And then if people are just on their own most of the day, and definitely one of the benefits of social prescribing generally in the arts is that not only do you go, say, to the comedy club or the art session, often you start sharing lifts going there, and you have a cup of tea afterwards, and all those bits are really important. So it's not simply a befriending service, because I think the arts have a bespoke role in getting people better, but I think all that stuff around it is really important as well. And we live in an atomized society, and it's really causing a lot of health harm, I think.
We so I know Jill Reynolds because she's part of the Tackling Loneliness project there, and we've actually I did a creative health and loneliness webinar, and we had lots of people come along to it because those creative health organisations know that they are doing part of that work, and they've actually started a shared learning group to take it forward. So it felt like, for me, a really sort of open door for creative health activity, and something that those people are really quite experienced in, actually. So it's such a boon. I think we're missing a trick really if we're not talking about loneliness. So let me ask another question.
Can I just answer something, because it's been in the chat? It's about because I know in London there's been a withdrawal of social prescribing services.
Yes, please do.
And I think what's happening is, I think that there may be a problem here in terms of local authorities stopping funding social prescribing or jointly funding, and then the primary care networks not bothering to pick it up, if you like. So that's something I think is a risk to social prescribing. And Monica, I think we need to be really wary of this, because it could start to get worse. So we must make sure that the link worker role is preserved, I would say. So just a little warning.
Absolutely. And so that leads into that question, is what's the best way for local authorities to support social prescribing? Because would anyone else like to talk about that?
Yeah, I'm happy to, because we actually did work getting social prescribing in as one of the recommendations for the Accelerating Reform Fund, which is all about kind of innovation in social care. And I think there is a huge scope and potential for it to be better connected. And I think there's a few different ways. I mean, this is a whole nother webinar, isn't it, really? You could talk about the potential of this for a whole hour, but I think the neighbourhood team working, I think, is an opportunity here in terms of how we wrap a team around a patient and how social care becomes part of that multidisciplinary team approach. So linking better and establishing good referral pathways between different services. I think there's some that local authorities have got perhaps the means, but also the mechanisms to enable some of that work to happen. I think there's also the local authorities have got a lot of scope in the providing the infrastructure that sits around social prescribing. So as I kind of mentioned that pathway earlier, there's all sorts of infrastructure that needs to sit around that. So things like the activity provision, community chests, designing services and voluntary sector services that are based on the need that's being identified through social prescribing, seeing it in that kind of system context. And there's really great examples and practice of that happening. And also things such as bodies, volunteers, you know, how can we add capacity to the system through the kinds of services that already exist within local authorities. So I think there's a variety of different means and mechanisms, but it should always be about what does the system currently look like and how can we add into that rather than duplicate by just building another workforce or building another X, Y, and Z when things are already happening and existing. But I think that the kind of neighbourhood health approach could be a bit of a gateway into enabling some of that to happen. But yes, I think there's a whole webinar on that.
Yeah, there is
another
another
that's just
webinar.
very brief initial thoughts.
I'll leave that one for you.
Can I just come in? I just noticed Charlie saying we hate Warwick, Edinburgh. A lot of people do. I think you don't have to use that one, but you got to use something, Charlie, when you do an evaluation. But no, I don't like. I hate all those assessment forms. So make it as light touch as possible. And maybe if anyone's listening on this call, if you could develop a good validated score that we could, it's not so invasive as Warwick, Edinburgh, that'd be great. We'd all love you for that.
So there are lots of evaluation available, and I'm going to be putting some information out at the end on the resources about the sort of creative health quality framework, and you know, so that people will be able to look at some of that recommended work there as well. I realise the time. I'm so interested in what you're talking about. I haven't actually, it's 2 minutes past 4. I think it's really interesting to have the different models, and I also want to just emphasise that. So we've had that. You know, there's the joint between the local authority and the Integrated Care Board. There's some, you know, community philanthropy, national lottery funding with sort of support for the continuation. I agree that there are different ways to bake this cake, but what I want is for more of the cakes to be baked. I want more people to have access to free creativity and social prescribing, and more social prescribers to really understand that strength, as well as those integrated neighbourhood teams really getting it, that what they've got on their doorstep to call upon as well. So not just thinking statutory services as part of that MDT, but really thinking about who is supporting who in their neighbourhood and appreciating that, and going on hopefully to perhaps fund some of that work in the future. So that's my dream, that we get, you know, the people that are suffering most health inequalities and wider determinants of health really getting some of that stuff that they would not access otherwise, that can really help transform their, you know, their well-being and their social health. Okay, well, thank you so much everyone for coming along, and I will be sharing the slides and the this recording as well. So please do share with people you think might be interested. Thank you so much.